All right, before we dig any deeper into our coagulation disorders or our primary disorders or fibrinolysis, let's talk about our routine coagulation laboratory evaluation. So this is going to be a brief overview just to give you a general understanding of the type of testing that we do, because I know throughout this secondary hemostasis portion, I've been mentioning things like PT and PTT and anti-10A and all of those things. And while I did give you a brief overview, this is going to give you a little bit more detail, okay? So the most commonly performed routine coagulation tests are going to include our ProTime INR, our APTT, fibrinogen testing, D-dimer testing, and anti-10A testing. Now, our anti-10A and our D-dimer are going to be more associated with our fibrinolytic system, but I do want to introduce them to you so that you have an idea of what we're talking about as we move further in to our discussions. All right, let's talk first about our ProTime INR. We utilize the ProTime INR to monitor patients who are taking warfarin. Sometimes you might hear it called Coumadin. And again, this evaluates the extrinsic pathway. It can be prolonged with anticoagulation therapy and factor VII deficiency. Those are the two primary causes. So warfarin use and factor VII deficiency. We might also see prolongation in deficiencies of the common pathway or secondary to other disease processes, like, for example, liver failure or disseminated intravascular coagulation, where that's a consumptive coagulopathy. We've kind of mentioned that back in our white blood cell unit when we talked about our AMLs. And essentially, that is where an overactivation of the coagulation cascade occurs, and it happens so rapidly and so in such a way that it completely utilizes up all of the coagulation factors that are available, as well as the platelets. So the INR is a standardization. It's called the International Standardized Ratio. It standardizes that ProTime so patients can be monitored from really anywhere. The reason why it's so important is because if a patient needs to have continuous monitoring of his ProTime due to warfarin use, the methodologies, the instrumentation, the reagents, they all vary a little bit from hospital to hospital. And this ISI takes into account the differences in methodologies, and then a calculation in the ratio form kind of standardizes that based on taking into consideration those testing differences. So if you go and you have a ProTime done at your hospital or your local clinic, and then you go on vacation and you have it done in a completely different area where they have different instruments, etc., your ProTime is going to perhaps have some variability, but your INR will still be within the same range. The ISI is an international sensitivity index provided by the manufacturer for each lot of ProTime reagent. So every time we get a new lot of ProTime reagent, we have to enter in that ISI so that our INR can be calculated. The normal reference range for ProTime is 11.4 to 15.0. And the INR reference range, well, a normal INR runs about 1.0, but there is a slight range above and below that. The activated partial thromboplastin time, sometimes called the APTT, or you may hear it just called the PTT, measures the intrinsic pathway. It can be prolonged with anticoagulation therapy, specifically heparin and direct thrombin inhibitors. There may be non-specific inhibitors like that antiphospholipid antibody syndrome, maybe that lupus anticoagulant, factor deficiencies, von Willebrand's disease, and even sometimes factor-specific inhibitors like factor 8 and 9 inhibitors. Extremely elevated APTT results are most often due to heparin contamination during the point of collection. So most inpatients who are receiving heparin while they're here in the hospital are given unfractionated heparin through their IV. And oftentimes nurses will draw blood samples for testing out of the IV. And it's very, very important for them to stop the heparin drip, flush the line, waste a sample, and then collect if at all possible, because we don't need that heparin to be in contaminating the sample. It does happen very frequently, though. Very rarely do we actually see an overheparinized patient, although it does happen. Reference range for an APTT is 22 to 34 seconds. Really, we're doing okay until we get up to like about 39, 40. That's when we really start to think about, oh, this is very, very prolonged. But yes, the normal reference range is between 22 and 34. Fibrinogen. We may see an increase in fibrinogen levels with people who suffer from diabetes, inflammatory conditions, obesity, pregnancy, oral contraceptions, infections, cancers. We may see decreased levels seen in consumptive coagulopathies like DIC, fibrinolysis, liver disease, and hereditary disorders. So afibrinogenemia, for example, we talked about on our last lecture, dysfibrinogenemia or hypofibrinogenemia. Those would all be deficiencies or inherited disorders. And then our reference range for fibrinogen is usually 146 to 390. All right, we haven't really talked about fibrinolysis much, but I'm going to just give you a brief introduction to one of the tests that we use as an indicator that fibrinolysis is occurring. And again, fibrinolysis is going to be associated with the breakdown of clots after they have been formed through coagulation. A D-dimer is a type of test that we use to measure fibrin degradation products. Now, fibrin degradation products are one of the byproducts of clot breakdown. There is another type of degradation products caused by a fibrinogen degradation, but our D-dimer measures the fibrin degradation products, and the byproducts of fibrin degradation are two D, we call them D remnants, but anyway, they're in a pair, so we call them D-dimers, and we're looking for those degradation products that are in D-dimers. We could see an elevation in DIC, deep vein thrombosis, pulmonary embolism, anytime really where there is a clot formation and our body is starting to break down the clot as it should. It can also be used to look at the efficacy of treatment for thrombotic episodes or screen for reoccurrence. So again, yes, we actually use this to make sure that the patient does not have a clot, that the thrombotic episode that they're having is decreasing due to our anticoagulant therapy, or if they have a history and they're symptomatic or they just go in for recheck, we are also checking for recurrence of thrombotic episodes. The reference range for a normal D-dimer is 0.00 to 0.40 fibrinogen equivalent units. If we start to see that increase, then that could be an indicator that we have a clot that is being broken down. Now, the thing about D-dimer is it can tell us that there are indications of clot breakdown, but it doesn't tell us where. And so it kind of just gives us a piece of the puzzle so that we can further investigate what's going on with the patient. But it can be a useful tool to kind of tell us what we might be looking for. Okay, the last assay that I want to talk about, or last of the routine testing that I want to talk about, is our anti-10A assay. Now, we utilize this test to specifically test for heparin. That could be unfractionated heparin or low molecular weight heparin. There are a couple of differences between low molecular weight heparin and unfractionated heparin, but the main difference is their administration. So unfractionated heparin is given in an inpatient setting via IV administration, whereas low molecular weight heparin is utilized more often in an outpatient setting. Patients can receive subcutaneous injections. It is also safe during pregnancy, whereas unfractionated heparin is not so much. The important thing is both of them have a proper blood collection technique that needs to be observed in order to avoid heparin contamination. In an inpatient setting where a patient is receiving IV heparin, we definitely need to make sure the collection occurs in the opposite arm as the heparin drip, and we need to have the RN turn off the heparin drip for at least 10 minutes prior to the collection. If the sample is to be drawn from the IV site where the heparin was administered, it needs to be flushed and then wasted and then flushed again before drawn. Occasionally, that anti-10A testing is ordered on patients who are receiving 10A inhibitors, such as rivaroxaban or apixaban. Sometimes we call these direct oral anticoagulants. Normally, anti-10A assay can indicate the presence or the absence of these medications, but cannot quantitate. However, we do have a new policy here at St. Luke's, where if it is requested by the pharmacist or the physician, we can go ahead and dilute the testing to give them a quantitation, even though we don't give them necessarily a value. We do document the value so that they can kind of have an idea of whether or not this patient is compliant with either drug therapy or discontinuation of this drug, because that's often what they're looking for. Is patients taking, for example, apixaban, and they have an upcoming scheduled surgical procedure. They want to make sure that those patients have abstained from taking the medication as directed, etc. Or maybe they're switching them over to a different anticoagulant and they need them to stop the old anticoagulant before they transition to the new one. So there are multiple reasons why. If you ever are in doubt about any of our tests, you're always welcome to refer to our policies and procedures. And in fact, I highly recommend it as you move forward in your career until you become familiar with all of the policies and procedures. It's just a really helpful resource. Anti-10A testing for unfractionated heparin, the therapeutic range for that is 0.3 to 0.7 international units per microliter or per milliliter. And then we have a little bit of a different therapeutic range for anti-10A low molecular weight heparin. So really depending if you're testing ultrafractionated or unfractionated or low molecular weight. But it's 0.5 to 1.0, so not a huge difference, but there is enough difference where you want to take note of that and just keep in mind whether or not the heparin that the patient is on is unfractionated or low molecular weight. And that concludes our routine testing menu. We will be moving forward and talking about some special coag testing, including our PT-PTT mixing studies, which we have briefly talked about, but really haven't dived deeper into. Once we have that lecture done, we are going to do the APTT differential test page worksheet. I'll have you guys work on those so that we can kind of determine, number one, what is a mixing study, and number two, what is a correction versus a non-correction, and number three, how do we determine which of those deficiencies may or may not be present, or are we looking at an inhibitor? So with that said, happy studying. I will see you next time.